Welcome to the deep dive. Today we're looking at something really specific, the kind of detailed planning that happens after major surgery.
We are. We've got a document here. It's called the Post-Aorta Bifemoral Bypass Protocol. It's by Dr. Gregory Weir, a vascular surgeon.
Right, aorta bifemoral bypass, big surgery. And this protocol is basically the step-by-step playbook for recovery right afterwards.
Exactly. It's about managing that immediate critical post-op phase. Think of it as navigating the patient safely after they've rerouted blood flow to the legs.
Okay, so our mission is to sort of unpack what's in this specific plan. What are the key things they're watching for?
Well, a huge focus right off the bat is vital signs, specifically mean arterial pressure, or MAP.
MAP. Got it. And there's a target range, I assume?
Yep, very specific, 70 to 100 millimeters of mercury. And there's a good reason for that narrow window.
Which is?
Well, if the pressure's too low, below 70, you risk the new bypass grafts not getting enough flow. They could, clot off.
Yeah, okay. Not good.
Not good at all. But if it's too high, over 100, you're putting extra strain on those brand new surgical connections, the sutures.
So a real balancing act. How does the protocol handle it if the MAP goes out of range?
Okay, so if it's high, MAP over 100, it's fairly standard. They titrate nitrosine, a vasodilator, to gently bring it down.
Okay. But what about low? Under 70?
Now, that's where it gets interesting. The protocol doesn't just say treat low MAP. It says check the CVP first. Central Venous Pressure.
CVP.
Oy.
What does that tell them?
It's basically a clue about the patient's fluid volume, how full the tank is, so to speak.
Coke.
So if MAP is low and CVP is low, less than 10 centimeters of water, the protocol says give a fluid bolus. Ringer's lactate, 250 millimeters an hour.
Suggesting the problem is likely just not enough fluid volume. Makes sense.
Exactly. But if the MAP is low, but the CVP is high over 10, you don't give fluids. The tank is already full, maybe even overloaded.
So what do you do then?
Then you reach for a vasopressor, like noradrenaline. Titrate that up. It suggests the problem isn't volume, it's maybe the heart pump or the vessels being too relaxed. You need to squeeze things up.
Wow, okay. That branching logic based on CVP is, well, it's really precise. It's tailoring the treatment to the likely underlying cause.
That's the key. It's not one size fits all. Beyond blood pressure, there are other standing orders too, right?
Yeah, standard post-op stuff, but still important, like oxygen mask if they're not intubated, keeping the legs elevated if they're swelling.
Elevation is crucial here to reduce edema, which could compress those new grafts, and keeping the hematocrit above 30%.
Hematocrit, the red blood cell percentage. Why 30% specifically?
Need enough red cells to carry oxygen effectively through those bypasses down to the legs. Oxygen delivery is vital for tissue survival.
Got it. And I saw something about a chest x-ray, CXR.
Usually to confirm the placement of that CVP line we were just talking about, make sure it's in the right spot.
Okay, moving on. What about lab work? Seems like there's a schedule.
Oh, yeah. Day 0, surgery day, they check HTT again, and TROP-T.
Troponin T. That's a heart marker, isn't it?
It is. Major surgery is a stress test for the heart, so they monitor it closely.
Then day 1, the list gets longer.
It does. You add UKE, that's urea, creatinine, electrolytes, a full blood count, FBC, and CRP.
CRP, C-reactive protein, inflammation marker.
Right. Tracks the body's inflammatory response to the surgery, plus myoglobin, which can signal muscle damage, maybe from clamping during surgery, and another TROP-T.
So quite a routine set of checks each day. How about feeding? When can they eat?
Not right away. Day 0 is nil per os, nothing by mouth.
Let the gut rest.
Exactly. Then day 1, they usually start very slowly with a feeding tube, like a Daub-off tube, maybe just 20 milliliters an hour. And they supplement that with TPN.
TPN, total parenteral nutrition. AV feeding.
Correct. Then on day 2, you see the progression. The Daub-off rate goes up maybe to 40 milliliters an hour, and the TPN rate comes down, perhaps to 60 milliliters an hour.
So a gradual shift. Gently wake up the gut, reduce the IV support.
It's all about minimizing risks, like Elias, where the bowel stops working while still getting nutrition in for healing.
What if the patient needed a ventilator during surgery?
The protocol covers that. Plan is usually ventilate overnight on day 0, then aim for extubation, taking the tube out on day 1 after morning rounds, assuming they're stable.
And finally, movement. How soon are they up and about?
Not for a bit. Strict bed rest for day 0 and day 1. Protect the surgical site.
Makes sense.
Then starting day 2, things change. They might start sitting up a bit semi-Fowler position and begin very gradual mobilization. A few steps, maybe.
So very stepwise. Prevent clots, help circulation, but don't overdo it.
Precisely. You put all these elements together, the MAP rules, the CVP checks, the labs, the slow feeding, the ventilation plan, the careful mobilization.
And you get this really detailed roadmap for recovery laid out by Dr. Weir. It shows the complexity involved.
It really does. It highlights the intense monitoring and proactive management needed after such a significant operation.
So we've covered the key areas: blood pressure control, the lab monitoring strategy, the cautious return to feeding, managing ventilation, and that gradual mobilization plan.
And looking at this level of detail, it really gives you a sense of the structured approach required in complex medical care, the vigilance involved.
Definitely. It leaves you thinking, though, with so many precise steps, day after day, for potentially many patients.
Yeah.
How do hospitals and teams actually ensure every single step gets followed correctly every time? What systems are in place?
That's a great question. And what does that kind of meticulous, protocol-driven care really mean for improving outcomes compared to maybe a less rigidly defined approach? So something to ponder.